Okay, good afternoon, everyone. My name is Franklin. I'm one of the two co-founders of NorCal SCI, which stands for the Northern California Spinal Cord Injury Foundation. Welcome to today's presentation on pain management after a spinal cord injury. Excited to have our presenter with us tonight. She's got a very complete and robust presentation that should answer a lot of your questions and also just develop a better understanding of why so many of us suffer from pain after our injuries. A couple of housekeeping items. So number one, you've all been muted, and that way we can eliminate any background distractions during the presentation. And also, if you have any questions that you want to pose to our presenter, there are two ways that you can do that. One is by using the chat feature on your screen. You can send those questions and I'll be able to read them to our presenter at the conclusion of her presentation. So we expect that this will be about a 60-minute presentation, so we'll have about 10 minutes time to ask the questions. Alternatively, you can also email the questions during the presentation to info@norcalsci.org, and I'll be able to pick up your questions during the presentation. This presentation tonight is presented through a generous grant from the RE Foundation. It's really part of NorCal SCI's Virtual is a New Reality series that we've been doing a lot of these things that we'll continue to do a lot more on an indefinite basis. So glad that we're able to get funded by the RE Foundation. And one last thing is that we are recording this presentation. And so if you need to jump off the call at any time, or want to revisit any of the things that our presenter is going to share with you, no worries. We will have the video recording available and we'll email it to you on Tuesday morning, roughly about 8 o'clock California time. So no worries about that at all. Okay, so without further ado, let me jump into our presentation and introduce our speaker. Our speaker tonight is Dr. Elissa Zakrasek. She's a board-certified physiatrist and SCI physician who practices spinal cord injury medicine at the Palo Alto VA and the Santa Clara Valley Medical Center in San Jose. Both of them are two of the really top spinal cord injury rehab centers in all of the states. Dr. Zakrasek has a special interest in pain management after SCI and has been responsible for pain education for the Stanford residents and fellows since 2017. She's currently developing a neuropathic pain clinic at the Palo Alto VA SCI Center. She completed her medical school training at UC Davis School of Medicine, followed by residency and SCI fellowship training at Brigham and Women's Hospital and Stanford hospitals and clinics. So it is my pleasure to introduce Dr. Zakrasek.
Awesome. Thank you so much. Let me just share my screen now. Okay, and we'll get started. All right, wonderful. Well, thank you so much, Franklin, and everyone for inviting me to speak today. As mentioned, pain management after spinal cord injury is a particular interest of mine. And I think you all know why that is. It's a very troublesome issue and a big problem for a lot of individuals that have a spinal cord injury, and one that hopefully will continue to develop more treatments for over time. But as of today, there are a lot of things out there. And so my hope today is to start sort of presenting some of these to you as options to think about. My goal here is not to be prescriptive and to tell any particular individual what you should do for your pain, but rather to give you ideas about what kinds of things are known and what's unknown and sort of the state of the evidence as it is today. So we'll get started. I don't have any financial connections to associations with any of the medications that I'll describe, the treatments or anything else therein. So I'm not biased by any particular financial gains for myself. And I will also say that I am only one doctor. So, you know, if you were to hear a similar talk presented by another physician, a spinal cord injury specialist, or a pain management provider, an interventionalist, they may have a slightly different view on it based on their own clinical expertise and experience with individuals with spinal cord injury or pain. And so, you know, again, I'm going to try to present this based on my personal experience, clinical experience, and also the evidence that's in the literature these days. So hopefully by the end of the talk, you're going to have a better understanding overall of how I look at pain when I'm treating individuals who have a spinal cord injury. So first of all, what type of pain can someone have when they have a spinal cord injury, and why does it matter that we differentiate these different pain types? Why do you have pain? What's the mechanism behind your pain? And then of course, what treatment options are available. So that includes non-pharmacologic, so non-medication options, medication options. Of course, people are interested. There's sort of a growing field in the field of sort of marijuana products. Then there's interventional options, and of course, surgical options. And I'll end with a little bit of information or guidance if people want to seek sort of ongoing trials and information about where you can find out what research is happening for pain management after spinal cord injury. So pain, according to the International Society for the Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. I like their definition because it talks about how this is an experience, and that's an important thing to consider for people having pain, because everyone experiences life in a different way, and therefore people experience their pain in a different way, and you as a person have a lot of influence on how you're going to experience your body and the pain that you have. So pain is complicated. When I present this slide when I lecture to residents studying physical medicine rehab and to the fellows who are studying spinal cord injury, as an example of, someone perhaps comes in and tells me, I have pain in my neck and shoulder region. And if this individual had a spinal cord injury in their, mid, maybe C4 level, it could be a lot of different things. It could be neuropathic pain, but it could be surgery-related pain. It could be a syrinx. It could be heterotopic ossification. It could be arthritis pain. There's a lot of different things that can be going on in the body of an individual who's had a spinal cord injury. And so one of the things that's important when you're working with your providers or clinicians when it comes to pain management is that they're asking you a lot of questions, and they're really trying to understand what is your pain and where is it coming from, because different kinds of pains are treated differently, and obviously different etiologies or different underlying mechanisms may even require something very different from just a pain pill to manage them. So what are the types of pain for someone who's had a spinal cord injury? So first of all, there's nociceptive pain. So this is the pain that you have when you overstrain a muscle, or you have arthritis or overuse tendinopathy in your shoulder or some other place. Or a wound. This pain is typically, stabbing or throbbing, aching. And oftentimes this will be a type of pain that happens when if you have shoulder pain, it gets worse when you move the joint. So that's nociceptive pain. That's, treated. I'm not going to talk as much about that type of medication management today. It's not really coming specifically from the nervous system, although, when we talk about the mechanism of pain, you'll also realize that all pain obviously goes through the nervous system. So in some ways, all pain is neuropathic to a degree. But this pain is a little bit easier to sort of quote unquote understand based on the mechanism of maybe a muscle injury or a joint injury. Then there's visceral nociceptive pain. So what does that mean? Your viscera are your organs. So this is your heart, this is your gallbladder, your stomach. So, if you're having a heart attack, you feel that squeezing, aching sensation. If you have gallbladder stones and biliary colic, you may have pain in your abdomen, or even pain that you feel in your shoulder. So visceral nociceptive pain is really interesting because it's the organ that is in trouble or having a problem, but sometimes we feel that in an unusual way. So this is often more of a diffuse pain, hard to localize, often more crampy or achy in quality. And sometimes the place where the pain is starting is not where we feel it. So the gallbladder is the prime example of that. If your gallbladder is inflamed, it might irritate your diaphragm. And if it irritates your diaphragm, the nerves that go to the diaphragm to feel the diaphragm, so you can sort of feel your diaphragm, they connect at the spinal cord at the same spot where nerves from the skin of your shoulder are coming in. And so your brain is perceiving it as if the pain is coming from your shoulder, but actually it may be coming from your gallbladder or your diaphragm. So obviously to treat this type of pain, we need to get at the underlying organ dysfunction. So what are we going to talk about today? That's mostly neuropathic pain. And even within the category of neuropathic pain, there are really a whole slew of possible types of pain you could be having. And the three primary types that we talk about in the field of spinal cord injury medicine is above level pain. So above level neuropathic pain being, someone who has a spinal cord injury, let's say in your mid back, let's say the T5 level. If you have tingling and burning in your hands, that could be from nerve damage, but that's not from your spinal cord. Your spinal cord level is below that. And so perhaps you have a carpal tunnel syndrome at your wrist or an ulnar neuropathy at your elbow. Something else is causing nerve pain. It's still nerve pain, but it's not coming from your spinal cord injury. So that's above level. At level pain, that's the pain that's often described as more of a band-like sensation or a belt, a tightness. So someone, again, with that example of it being an injury at your thoracic level, you might feel that sensation right around the level where your spinal cord damage actually is. And then below level pain, so that's the pain we consider to be more centralized pain. It's pain that's happening below the level of your spinal cord injury. So if your spinal cord injury level is in your neck or your mid-back, you know, you might have tingling, burning sensations in your legs. That's what we consider below level pain. So most of what we're going to talk about today, obviously, is neuropathic pain and these different types. So you might say, why do I really care what kind of pain it is or what you're going to call it? Because at the end of the day, I really just want you to treat it. I'm uncomfortable. So I argue that it's actually important to know what kind of pain you have, and it's important to talk about it the right way. It matters in terms of how I talk to another clinician and how I'm going to communicate about an individual and what kind of pain they have. And also, you know, what kind of choices of medications we're going to use. For example, if you have below level pain and you have tingling and burning in your feet and it's very uncomfortable, but someone else thinks that you have shoulder pain from your arthritis, well, those shouldn't be treated the same way, and they're certainly not the same thing. We're talking about an apple versus a pineapple. But if you even consider within the category of neuropathic pain, there's still different types, right? So somebody could have neuropathic pain in their wrist because of carpal tunnel. Well, again, that's not the same neuropathic pain that you have in your legs if your spinal cord injury is in your thoracic level. So even within one category of neuropathic versus nociceptive, there's still different types. So really the goal is to be treating and comparing one type of the same type of pain to the same type of pain. And I'd like to think we can even take it a step farther so that we're not just saying one person's at-level pain is the same as another person's at-level pain, but even that we're describing one person's burning pain as another person's burning pain, or their electrical pain as another's electrical pain. And that hopefully someday we'll really understand the true nuances of the different types of pain, what's causing them at a molecular level, so we can then treat it appropriately. It's the direction that the field is going. So really, to have a good example of why these mechanisms might be different, a prime example of this is really just differentiating at-level versus below-level neuropathic pain. So in order to understand the differences here, you have to know the difference between the central and the peripheral nervous system. My apologies, probably a lot of you already know this difference, but when we think about the central nervous system, we think of the brain and the spinal cord. When we think about the peripheral nervous system, we're talking about all the nerves that come out of the spinal cord and go to the body, that go to the skin and go to your organs and your muscles, etc. So when we talk about peripheral nervous system pain, examples of this might be diabetic neuropathy, a trigeminal neuralgia. There's different areas, or, you know, as I described, an above level neuropathic pain from carpal tunnel, for example. When we talk about at-level spinal cord injury or pain in someone with a spinal cord injury, really this is a combination of a central nervous system pain and a peripheral nervous system pain. If you imagine someone that has a significant trauma, let's say they're in a car accident leading to their spinal cord injury, you might imagine that at that level where there's been a dislocation or fracture within the spinal cord and the vertebrae, that you maybe not only damage the spinal cord, but perhaps also damage some of the nerves as they're leaving the spinal cord. So you then therefore may have damage both within the spinal cord, within the central nervous system, and without. And then even within the spinal cord itself, we have the gray matter, which is where all the cell bodies are from our neurons, and then the white matter, which is where the long axon tracks travel up and down the spinal cord between our brain and then down to these cell bodies. So whether you damage the gray matter or the white matter, that also matters. And so as you can imagine, looking at someone who has pain below their level of injury, we're thinking about, okay, there's damage somewhere higher than that in the spinal cord, and it's those white matter tracts that are affected, versus at that level of spinal cord injury, that pain is coming from something different. It may be some white matter damage, but it may also be gray matter damage. It may be damage to the peripheral nerves. And so again, this is just an example of why it matters and how these different types of pain are different, why they probably feel different for a lot of people, and therefore why their treatments may also need to be different. So right now, probably a lot of you think, and honestly as a physician I can say, that whether somebody's pain is burning, cold, vice-like, electrical, a lot of times we treat it the same. That's sort of the current state of the science. And a lot of you might think we just give everybody gabapentin. And to a certain degree, you're right. We do use a lot of gabapentin. But ultimately, the reason I talk about this differentiation of pain is someday, hopefully, we'll have different medication choices that are really optimized to different types of pain. And, not necessarily just what it feels like, but what that feels like then correlating to the real physiology and molecular mechanism of why you're feeling that type of pain may then respond best to a particular treatment. And so again, that's where we hope the field is going, and there's efforts in that direction. We're not quite there yet, but I still think that even where we are today, it's important to make sure that your physicians, your providers know what kind of pain you're having, where it is, to be hopefully moving towards treatments in the most sort of specified direction as possible for your particular pain. So why do you have pain at all? So pain is a complicated mechanism that essentially is going from the peripherally through the central nervous system and back again. So it's involving your peripheral nerves, your spinal cord tracts, it goes through the brainstem up to the brain where it's processed, and then you actually have a modulating system that then comes back down. So thinking about it another way, if you accidentally stab your hand with a nail, you're going to feel that with your peripheral nervous system. It's going to travel up on these fibers, connect in the spinal cord with other neurons that then travel, they transmit that signal up to your brain, and within the brain you have processing. And it's important the type of processing that happens and where it happens. It's happening in the prefrontal cortex, it's happening in the amygdala, what we call the limbic system. This part of the brain is important for our emotional and sort of cognitive perception of things, including pain. So we're processing it in these emotional areas, and then there's a descending modulation that then heads back down the spinal cord and modulates our pain. It goes back through the spinal cord tract and either increases or decreases this overall sort of cycle and perception and feeling of pain. So as you can imagine, if you have a spinal cord injury somewhere in this, tract up and down, then you're going to have the way that you perceive pain is going to change. Or you could even develop new areas of pain that's not coming from a nail in your hand, but coming from nothing, where you start to have this pain. So the other important thing to take into account here is this brain, cortex, amygdala basic processing of your pain. Pain is a sensory and emotional experience. So when a physician says it's all in your head, it's not that you have pain just coming from your head. The fact is, this is where we perceive it. Our brain is our perception center. That's where we're going to experience the pain. And so there is a large component of your pain that is being, incorporated, processed in your brain, and affects the way that you feel it. Therefore, if you do have depression, if you do have anxiety, most likely your pain is going to be worse. And vice versa, if you have pain, oftentimes it makes your depression, your anxiety, and these other things worse as well. And so it's one of the reasons, as we'll talk about medications, that we often use these antidepressant medications. They have been shown to have overlapping effect for neuropathic pain specifically. So when we talk about neuropathic pain, the person that doesn't have a nail through their hand, and yet they still feel pain as if they have a nerve through their hand. So why is that? So along these pathways going up and down, the basic two principles is that there's disinhibition and a hyperexcitability, this hypersensitization of these nerve cells. So they're sort of firing when they're not supposed to be, and they're sending pain signals that aren't really there. Why does this happen? There's a lot of inflammation within the spinal cord and from the spinal cord injury. There's an upregulation and sort of a overstimulation of some of the ion channels that are either supposed to inhibit or create some of these pain signals. There's different, communication between our glial cells and our damaged neurons, and there's even changes within the brain itself. They've looked at studies where there's just increased activity within some of these areas for certain individuals that have neuropathic pain after spinal cord injury. So there's a lot of different things going on, and a better and increasing understanding of these different mechanisms is where we try to head when it comes to the treatments. So what are those treatments? That's probably why most of you guys came today, is to have a better understanding of what treatment options are out there. So again, this is, I'm trying to present a lot of the treatment options that are out there. There's more, it's sort of impossible to get to them all. And the real focus is meant to be on the data that's behind the treatments that are available. One thing I'll say in that regard is that it's really hard to do good research with spinal cord injury. And as you can imagine, it's even harder to do good research with pain. And part of the reason for that is because you want to have, ideally for research, you have a group of people who are all almost exactly the same, that have almost exactly the same problem, and you use one treatment. So you can see whether this type of people with this type of problem respond to a treatment. The problem is everybody with a spinal cord injury is different. Your spinal cord injuries are different, whether you have a complete injury, an incomplete injury, an injury from a gunshot wound versus an injury from a car crash. They're all different. Then you add on top of that, that their pain is different. So you're trying to group people in a study that have at-level pain, that have below-level pain, that have tingling pain, and have burning pain. And so then you give them a treatment. And so sometimes it, quote unquote, doesn't work, or it doesn't work very well. But the problem is it's hard to generalize a lot of these results because we don't know for you, you might have been the one person in the study that did really respond, or vice versa. Maybe this treatment worked for a lot of other people, but it's actually not going to work for your particular injury and your particular pain. So what are a few guiding principles that I think about when I'm looking at medications and other treatment options? Number one, the obvious one is risk versus benefit. So, obviously I don't want to use a treatment option that's got more risks than it's actually going to help an individual. On the same sort of line of thinking of that is the idea that less is more. And I think this is particularly true when it comes to medications. Unfortunately, every medication has a risk of side effects. The more medications you have, the more they may interact with each other. And even if they don't have an effect today, they could have sort of cumulative effects for you in the long term. So overall, if you can get away with fewer medications, fantastic. And then finally, this falls within the context of a human being. And a human being is very complicated, multifaceted. You have a lot of different things, as I've described, in terms of your injury and who you are. And so, given how complicated we all are as individuals, clearly pain and your pain management may be equally as complicated and certainly not simple. Two other very important principles that you have to think about with pain management. Number one, when I think of risk, benefit, and costs, it's also truly the financial cost that you have to consider. So, it's easy to say that I'm going to recommend that you go and have, transcranial magnetic stimulation and try, this new brand name medication, but you may not be able to afford it. And so, it does matter. And I think that if you're going to try something that's expensive or you see something advertised that's expensive, that is part of the risk. Because if it doesn't work, you may not be hurting your body, but you are going to hurt your bank account. So you do need to think about whether or not you're willing to assume the financial risk of trying some of these things, especially if there's not a lot of data behind them. And then the second image is basically supposed to depict the fact about, what is your goal when it comes to pain management? As a provider, unfortunately, most of the time I have to tell people that my goal in treating your pain is not to bring your pain score from a 10 to a 0. My goal is to bring your pain score from an intolerable to tolerable. And most importantly, my goal is to improve your function, to improve your sleep, to improve your quality of life. So I'm looking at outcomes like, this is someone that used to go out every day and tinker in his garage and do some activity that gave him joy in his life. He's had too much pain to do that. Now he's starting his medications and he's doing that again. To me, that's a pain treatment success. Whether or not that number changed a huge amount often isn't as important to me as what they're really able to do based on how they're feeling. So again, context is everything for pain management. When it comes to spinal cord injury, like I said, the type of spinal cord injury you have matters. We know that people that had a gunshot wound that caused their spinal cord injury, they often have a lot more pain than people that had a spinal cord injury from a different mechanism. So these things do matter. Other medical illnesses. There are certain medication choices I cannot use if you have liver failure or liver disease, if you have kidney failure, kidney disease. So these things do matter and we should be looking at it in the total context. And then of course, mental health. There's certain medications I might choose first for one person, but for somebody else, I might go a different route because I know that they also have underlying depression. So this is important. It's also important in the context of people that have a history of abuse of some substances or medications. And so we do have to pay attention to that kind of thing and weigh that into the medication choices that we make. And then of course, access. So this I see every day when I go from my job at the VA to the job at a community hospital. The types of choices and opportunities people have for treatment, it changes, unfortunately. And it's unfair. And the fact that it frustrates me, I can't even imagine how much it would frustrate you because it doesn't make sense. We should have the same things available to whoever needs them. But the reality of the situation is that we don't. And then even within people, within the VA, if you have a service connected or not, and outside of the VA, if you have one insurance or another insurance, you just may not have access to the same thing. And then from even another element is just, do you live in sort of the boonies of Northern California or do you live in a city? How far are you willing to travel? All these things matter in terms of what your options actually are in terms of your management choices. So you may see some of the slides where I touch a little bit about how strong the evidence is for some of the things that we offer and we use for pain management. This is one of the scales that we end up going off of. And so you'll see some things with level 1, level 2 evidence. That's the goal. We wish that everything had a big randomized control trial to see whether it's truly effective. unfortunately, most things with spinal cord injury medicine in general, we don't have that level 1 evidence, but we do the best we can. And that's where sometimes really looking at the study specifically and the subgroups and the specific people and trying to see who benefits, sometimes that's what it comes down to. But I do look at this when I'm doing my risk-benefit analysis. You know, I'm unlikely to offer something that has really high risk and a really low level of evidence. We do hope that that evidence is pretty good before we start something that could have a potential significant risk for somebody. So what kind of non-pharmacologic, non-medication treatments are available? So most of the treatments we have that are not medications, they rely on sort of one of these basic principles of either distracting you, because again, your pain is processed in your brain, and if your brain is thinking about something else or doing some other processing, it may not focus as much on the pain. Another theory, which I'll talk about next, is the gate theory of pain. A lot of different treatments basically rely on this theory, and then also anti-inflammation or anti-inflammatory effects. So I'm not talking about a steroid or a non-steroidal anti-inflammatory drug, but I'm talking about the inflammation that we know is part of the changes that happen within the spinal cord that cause the hypersensitivity and the overexcitation leading to pain. If we can get at some of that inflammation, then perhaps we can get at some of the pain. So the gate control theory of pain, what does this mean? So if you've ever seen anyone, you know, stub their toe or bang their arm and then they rub it, and you rub it, and why do you rub it? You just hurt that area, but now you're rubbing it, and it's like we have this just innate just instincts to go and like rub that area of pain. So this is the gate theory. The idea being that, you know, you've just, you know, stubbed your toe, and so now you bend over and you rub your toe. So there's two stimuli, two different nerve sensations are traveling through two different nerves. They both have to kind of go through the same gate, the same passageway in the spinal cord to make it up to the brain. So if you have two sensations, maybe that deep touch, that rubbing sensation, if that one can kind of get in the way and block some of that really painful sensation, then maybe you're not going to have as much pain. So this theory is used frequently in pain management. It is mostly theory, but whether or not we completely understand the mechanism by which this happens, I think most of us can argue that there is something to it. There is something to the fact that if we hurt a certain area and you rub it, it somehow seems to make it feel a little bit better. So we use that when we use things as simple as compression. So abdominal binders, compression gloves, compression socks, these sometimes help people with pain. It's based on that gate control theory because they cause a pressure sensation. And so there's no data for this in spinal cord injury medicine, but we do use it. Occasionally people will have tingling or burning in an area, or they'll have that at-level pain, and we'll put an abdominal binder around it. The idea being that maybe they're going to feel that pressure of the abdominal binder, and maybe it'll mask or kind of get in the way of a little bit of that at-level pain. Most of the time, the risk is pretty minimal to try these if you can afford it, or if you can be prescribed one of these compressive devices, as long as you watch out for the skin. So, you know, I definitely have seen wounds, especially people that wear compression socks for lower leg swelling. If those things get rolled up, they can definitely cause skin injuries. So you do have to pay attention to that. But otherwise, pretty low risk. And for some people, this is helpful, not for everybody. Electrical stimulation, based on the same theory. You're sending an electrical signal through some of those cutaneous nerve fibers, and instead of you feeling the pain signal, instead you're feeling these electrical jolting sensations. So these are TENS units, these are H-wave units. The data here is inconclusive. There are some studies that suggest it's pretty effective, others not so much. It does cause some spasms in some people even report more pain. But you know, at least some of the studies, here's the results of one kind of comparing low frequency versus high frequency. And you know, a good number of people, this was specific to spinal cord injury, felt that they had rather good effect or very good effect. So it may not work for everyone, but I would argue that in some cases, I mean, on a lot of cases, if you can get one of these without a huge expense, it may be worth a shot. This is also very effective in many cases for more of a nociceptive pain. So for people that have, you know, shoulder discomfort and some muscle tightness in their neck and shoulders, this can also be helpful for that. You can't use these electrical stimulation protocols if you have cancer, other like implanted devices like pacemakers, pregnancy or seizure disorders, because they can potentially spread cancer, though I don't think that's ever been shown, and could potentially cause seizures, etc. What about physical activity? So the idea behind physical activity in pain, number one, it's probably distraction. Number two, physical activity most of the time is just good for everything. I'm a spinal cord injury doctor, but I'm also, you know, an athlete. And I think in general, I'm always going to advocate for physical activity. But, you know, The problem with actually trying to study physical activity and pain is that what do you mean by physical activity? You know, there's a gazillion different things you can try, different intensities, different protocols, different activities. So it's really hard to compare, you know, person to person, study to study, and to say whether it really helps. But there's been at least some recent sort of reviews trying to draw it all together. And the overarching argument is that, yeah, it probably does help reduce some pain. And even if it's not directly affecting pain, it's improving function, it's improving quality of life. I say it's probably a good thing no matter what, as long as you can find something that you can access that's good for you, you know, do it in a safe way. Obviously, exercise, you know, some wheelchair rugbies and things like that can be dangerous, but don't cause new injury. And it generally is a good thing. Diet. So a really interesting study that came out a couple of years ago looking at an anti-inflammatory diet. What did that mean? They basically took out all of the food choices that people are often have allergies to or intolerances to, like milk. They gave them a bunch of anti-inflammatory supplements, and they looked at the anti-inflammatory markers and directly correlated that to neuropathic pain. And they had good results. The problem is they stopped the study and they looked at people a year later, and most people stopped the diet and their pain came back. So, you know, these type of interventions, they can work, they can help, but you got to stick with them. You know, is there a risk to this? I mean, it could be very healthy and good for you in other ways. It could be costly. I'm not exactly sure, but in general, I would say, you know, having a healthy diet, overall healthy body is probably also going to help with your pain. Virtual reality, it's become a big, you know, fad right now. I live in Silicon Valley, so obviously everyone likes technology. Again, this is a tricky one. There's a lot of different types of virtual reality. There's virtual walking, there's virtual reality combined with rehabilitation and actual movement versus VR where you're just sitting there looking at something. Overall, the study suggests that people do have pain reduction with their neuropathic pain. The length of time that it helps is variable. So some people, you got to be sort of in the experience or shortly thereafter in order for that pain effect to really matter. And obviously that's not very sustainable because you're not going to go around your life wearing a VR headset. But, you know, there's some evidence there. And again, this goes in line with maybe distraction as well as this whole central processing and sort of limbic system, your emotional responses to pain. Some people get distressed by the VR experience, so it's not for everybody. It can have some risks. Transcranial magnetic stimulation, I haven't personally done this. I work with someone who's done it more in the context of depression. It's being used in depression. It is being used in pain. Again, I mentioned there's similar pathways for both of those situations. Essentially, you have this depolarization of neurons that no one understands exactly how this works, but it does seem to help with some of that central pain. Not so much your at level or your peripheral nervous system pain, but more of that central, perhaps below level pain. So, you know, it can have some risks. And the other issue is just access. I look to see, you know, what kinds of, you know, TMS is available in Northern California. There are some centers out there, but again, it's not available for everyone. Acupuncture can be helpful, you know, just any acupuncture, the studies, you know, try to look at it, but everyone does a slightly different protocol, helps some people, doesn't help other people. There's a new sort of promising evidence looking at battlefield acupuncture where they put it in the ear, they leave it there for a couple days actually, and it actually shows some promising effect for central pain. The theories behind this are based a lot more on sort of Eastern medicine practices. I'm not as familiar with them. The risks are pretty minimal. If you have access to trying this, it's worth a shot in my mind, but I don't have personal experience with prescribing it. So pharmacologic options. When I talk about these with the residents, I actually do use the phrase, you know, pick your poison. The reality of the situation is all medications are sort of poisons. You do have to look at the risk and the benefit of taking them, and they can have side effects. So, you know, sometimes we need them and they can be very helpful, but, you know, we have to look at them in the total context. What medications can we use? The gabapentinoids, definitely. Antidepressants, antiepileptics. Yes, we do use opioids sometimes. There's some other medication choices out there. This is sort of generally a lot of the ones that we use, sort of in the order in which I use them, but that very much depends on the individual. The reality of the situation is I often tell people, you know, it's great. We have a huge number of choices for medications we can use for your neuropathic pain. Wonderful. Also, that's terrible. It's terrible that we have so many medication choices for your neuropathic pain, because if we had one or two that actually worked, then we wouldn't have, you know, 50 other ones that we could try. So, you know, sometimes it's a journey to try to find what's going to work for you. Gabapentin, it acts on the calcium channels. We talked about sort of this overactivity of some of these ion channels causing the hyperexcitability. It does have a lot of theory as to why it should work, and it does. It's got level 2 evidence for pain management. It has a lot of side effects, but in general, I'm going to put a gazillion side effects for every medication that I list. And honestly, I could fill every slide with potential side effects. So, you know, if you get your list from the pharmacy, there's always more than you can read. Yes, the side effects are potential. Different people experience them in different ways. In general, I would say most people tolerate gabapentin pretty well. I do have some patients that won't tolerate it because it does kind of make them a little cloudy and they can't focus or function as well in their day-to-day life. Pregabalin or Lyrica, very similar mechanism of action to gabapentin. It does bind a little bit more strongly to those calcium channel receptors and it may act a little bit more rapidly. It is actually the only medication that is FDA approved for spinal cord injury related neuropathic pain that is on the market. It has level 1 evidence for pain and the only one for which that is true. And it's also been shown to improve sleep. It also has a lot of side effects. It's pretty similar to gabapentin, some a little bit different, but it again depends on the individual. And so the real question is, you know, everybody gets gabapentin, what should we use? Someone actually this year did a comparative study trying to draw all the studies together to see, you know, which one actually works better. And they really couldn't find any significant difference between the two drugs. So, you know, it's tricky. Some guidelines say we should always start with Lyrica. Some of the guidelines say just start with gabapentin. I don't know. The reality of the situation is most of the time we start with gabapentin because it's easier to get and it's cheaper. And if it doesn't work, then we'll try switching to Lyrica. The antidepressants. So tricyclic antidepressants were used in the past. They're an older form of antidepressant. They can be effective if you also have depression. Otherwise, they don't have a huge amount of efficacy. They work on the 5-HT stands for is a way of describing serotonin, and NE is norepinephrine. So they're working on the same neurotransmitters that are involved in depression. They're also part of that pain modulatory system. They have side effects, and a lot of the side effects with these TCAs, they're problems for people with spinal cord injury because they dry you out. They can cause urinary retention. That's a problem for someone who's trying to pee on their own and already has a problem with peeing. They can cause constipation. We know that can be a problem for everyone. So these are not often as used as much as they used to be, but they are still used and they can be effective for some people. More often now, if we use an antidepressant, we'll use the SNRIs like duloxetine or venlafaxine. These have a lot more evidence. Well, the duloxetine has a lot more evidence for peripheral nervous system pain, like diabetic neuropathy, fibromyalgia. So most of the guidelines recommend trying it for more of the at-level pain, which has probably got some peripheral nervous system involvement. Venlafaxine, the only evidence for that in spinal cord injury pain is actually for more nociceptive pain, specifically with people in depression. It was one study, it was a subgroup analysis. You know, theoretically it should work pretty similarly to duloxetine, so sometimes it comes down to insurance coverage, but I will try these ones frequently. If someone has depression, I will often use one of these even before I would use a gabapentinoid. They also have side effects for people with spinal cord injury. That decreased libido or erectile dysfunction can be a really big deal as it is, and so sometimes that can be a limiting factor to the use of these medications because they can get in the way. Other anticonvulsants that can be used, lamotrigine does have pretty good evidence for effect for neuropathic pain if you have an incomplete spinal cord injury, not if you have a complete injury. Carbamazepine, carbamazepine, topiramate, they've got some indications, FDA indications for other types of peripheral nervous system pain or even migraines. I've actually had some pretty good benefit for some of these medications in a variety of different patients, but you know, they do have different side effect profiles, often a lot of cognitive slowing that we do have to pay attention to, and specifically for lamotrigine, it's one I've actually been very cautious ever using because it can lead to a life-threatening skin condition in very, very rare cases called Stevens-Johnson syndrome. But again, you know, these medications, they're there, but you do have to really pay attention to what the risks may be. Opioids. You know, I don't like to paint a terrible picture of opioids. I do think that they often have a time and a place. They do have a lot of risks, and they have risks that really affect people with spinal cord injury. They cause constipation. You know, you have neurogenic bowel anyway, you're trying to get a regulated bowel system, you add opioids and it can be a real challenge. Similar to this whole idea of erectile dysfunction and sexuality, they really affect that. If you're on high doses of opioids, it affects your hormones. It leads to hypogonadism, it leads to lower testosterone and erectile dysfunction. They've been recently associated with increased fractures for people after spinal cord injury. And of course, as with anybody, they can have risk of abuse and overdose. And, you know, I can't explain this, but there was some recent studies that came out saying that people with spinal cord injury are actually at higher risk of developing addiction disorders with opioids. I don't know that I necessarily believe it, but there is some data suggesting that, which may make certain providers a little bit more hesitant to prescribe them. Acutely, so right after spinal cord injury, we should really be trying to minimize opioids. They can actually increase your risk of developing neuropathic pain chronically if you use them very early on. And they may also be associated with worse motor outcomes, worse sort of locomotive movement outcomes after your spinal cord injury. So, you know, especially in those early phases when unfortunately we need the most, people have had surgery, they may actually have a lot of negative effects for people. How do they work? They just decrease a lot of this neuronal excitability. They have you have a lot of opioid receptors in your central nervous system. And I'm not going to lie, there is data out there that says that these can be effective and improve quality of life and pain for people with spinal cord injury. There's also studies that say that they don't help. And, you know, one of the most prominent people in the field of spinal cord injury and pain management, Dr. Thomas Bryce, he put out a paper, you know, just 2 years ago to, you know, to providers, to people reading about spinal cord injury medicine, saying they should not be prescribed for chronic pain. He argues that there's not enough data. He argues that the side effect profiles are just not worth the risks. And, you know, certainly the risk of tolerance, abuse, dependence, and overdose. For some people with spinal cord injury where they already have issues with their breathing, we know that opioids can affect our respiratory drive. So, you know, some argue that we should really be trying to avoid them altogether. Tramadol is a sort of opioid-like medication. It's a sort of synthetic style opioid, but it also has some of those same serotonin norepinephrine effects in addition to the opioid effects. It has some known benefits in neuropathic pain. And it doesn't seem to have the same effects in terms of, you know, motor outcomes or functional outcomes if used early. So maybe it's a little bit better if we need to use something down this line. It does have a lot of side effects. And in fact, there's one study of 23 people with spinal cord injury that were given this medication in a pain trial, and 11 of the 23 people dropped out because of side effects. Interesting, because I actually use Tramadol frequently when I'm trying to get people off of some of the other opioids. I haven't seen a lot of people stop it for side effects, but you know, the data suggests that people do suffer from significant side effects. So what about cannabis? You know, it's an interesting topic and not one that I often get to talk as much about. When I work at the VA, I cannot prescribe or recommend cannabinoid products, but I do want people to feel safe to discuss it because I want to know if it's working. There is more data coming out. And certainly I need to know, as I'm kind of coming up with a total pain regimen, what somebody's on. I don't want someone to feel like they're in trouble for using them. On the flip side of that, when I work at the Valley Medical Center, you can be in acute rehab. You can bring your, you know, your marijuana product into the hospital, and they will dispense it to you from the pharmacy. So if you go to one of the local dispensaries and you have some THC or CBD products, they can actually dispense them to you in the unit. So, you know, that just goes to show that even within a very small geographic area, there are very different approaches to how we can use cannabis products. The data, so the mechanism, not completely understood. There's tons of compounds in, you know, the marijuana leaf, et cetera, that could be playing a role. There was a recent, you know, again, larger review trying to give an overall gestalt message. Do they work or not? The sort of scientific answer is effect, sort of a significance unclear. We don't know the best route to give it. We don't know the best composition, concentration yet. And the reality situation is it's still not FDA approved to treat any disease. It does have side effects. I think the cognitive ones are important to consider. I think it also matters how you consume it and sort of what percentage of THC versus CBD. Unfortunately, we don't yet have the data to make enough recommendations in that regard. So are people using it? Yes. Someone did an online survey of prior users, current users, never users. Most people said they felt like it really gave them great relief of their symptoms, looking at, you know, pain and spasms, sleeplessness, and anxiety. And they felt like it was more effective with less side effects than their medications. Sativex is a medication that's a combination product, a spray that's used in Canada. It's been approved up there. They use it for MS-related spasticity, not for pain. It doesn't have evidence for MS pain at this point in time. Other data, so Dronabinol, Marinol, this is a medication we can use. We can prescribe it at the VA. We use it as an appetite stimulant. It does not work for pain. It's a synthetic THC only. Vaporized, so there have been a couple studies looking at this. Unfortunately, you know, it's like 8 hours. They have people do some vaporized marijuana products, and then they have immediate pain relief, but they didn't follow them afterwards. So whether or not it's helping sort of with long term, and they also weren't able to look very in depth at the cognitive effects, my argument is that we still just need to know more. So there is ongoing research. The same scientist that did the really interesting study on the anti-inflammatory diet is actually currently recruiting for a combination cannabinoid and anti-inflammatory diet to look specifically at neuropathic pain. So hopefully there'll be more to come on this. What kinds of interventional treatments can you pursue? Stem cells. Everybody's always talking about stem cells. I'm going to just leave it at this. Basically, the studies are all preclinical at this point, and we don't know. Some studies actually show that you give mice or rats stem cells and their pain gets worse. So I really think a lot more has to be done here before we start looking at specifically stem cells for pain. They are using stem cells for other things, but they're mostly being used very acutely after injury. So at this point, I can't say. Other infusions, so lidocaine, there's studies looking at this. It's a sodium channel blocker. It does affect the hyperexcitability of the nervous system, and it is very effective, but it's an infusion. You get it, you have to be monitored. The pain effect goes away, you go home. You can't go in every single day to have this procedure done. So it also has quite a few side effects. Intrathecal medications, you've probably heard of people with ITP pumps or intrathecal pumps. They're great for spasticity, and they also help people with pain, whether it's spasticity related pain or working on pain receptors itself. We don't know as much yet, but it can be helpful. You can get a pump with morphine in it, or with morphine and niconatide, another calcium channel blocker. It's actually been shown to have fair evidence for nociceptive and neuropathic pain. So these are out there. You got to work with pain centers as well as neurosurgery to have these implanted. Other surgeries. So some of these start to get more invasive. So a DRES procedure, they're literally going to have to cut into your back, open things up, get to your spinal cord, and start sort of ablating or burning part of your spinal cord. You're not going to want to do this if you have an incomplete injury. You will come out of it and you will lose sensation. You are burning some of your sensory neurons. But in the cases where people have refractory pain where this has been done, the data is actually pretty good. But it is a surgery. It involves opening up the spinal cord or the spinal vertebrae. And so, you know, it's not something that anyone's going to do as a first-line treatment, but there are cases of refractory pain where this can be done. And I have had a patient who's had this done. Other implanted devices, so spinal cord stimulators, peripheral subcutaneous field stimulation. So PSFS, basically it's like TENS, except it's implanted under the skin. It's the same gate theory of pain. It's masking pain. It's sort of creating a new tingling sensation, which is supposed to kind of mask the other pain that you had. There's an interesting case report of one person with an incomplete injury, or at-level pain, I'm sorry, used this thing for 5 years, found it incredibly effective. It's a case report of one person. So it's hard to say a lot, but you know, maybe there'll be more to come. Spinal cord stimulation, sometimes you can have it sort of do a trial run. They'll put in the implanted lead. Again, it's a big surgery. You got to open things up, put it by the spinal cord. You stimulate the dorsal columns, which is where we have our sensory nerves come into the spinal cord. It can be in there for a long time. At this point, it's sort of unknown. There is some potential pain relief. They quote the studies are low quality. That's because they're small studies with a mixed population. In some of the people, it loses effect over time, but now you have this implanted hardware in your back, in your spine. So more needs to be done. But again, if you really get to a point where nothing's working, you know, you can talk to neurosurgeons and the pain centers. Does have risks. People can have, the leads can move, the hardware can break down, you got to change the batteries, it can become infected, it can actually develop sort of a whole big scar, fibrotic thing around it, push on your spinal cord, and there's been case reports where it's caused a new spinal cord injury for people. So these things, they're not without risk, and that's why they're not taken lightly. You really need to fail other things first. Deep brain or motor cortex stimulation, the reality situation is more data is needed. You know, by the time you're going to open up somebody's skull and put in some leads and do things, the data, there's a few case reports in spinal cord injury that say that it's effective, but these are, you know, at least as high risk, if not higher risk than the procedures that are done on the spine. And so I really think at this point, you know, I've never recommended any of these procedures to be done. But, you know, if your pain gets to that point, you've tried everything else and failed, and it's really affecting your quality of life, they're out there. If you go to the right center and you talk to the right people, it may be available. So I just want to end with red flags. Your pain may be trying to tell you something. So if you have new pain, don't just chalk it up to, okay, I've got a spinal cord injury, of course I have pain. You know, sometimes your pain is trying to tell you something. You might have a new infection, you might have a wound, you might have an ingrown toenail, who knows what it is. But sometimes your pain is a signal of something else. The same way that autonomic dysreflexia is telling you your bladder's full or you need to have a bowel movement. The same can be true of your pain. If you have neuropathic pain, you know, ever since your spinal cord injury, and now it's a lot worse than it was, you should probably have a workup or an evaluation to figure out why that is. It's not part of the natural course of disease to have this progressive or new pain years after an injury. It should be worked up. Other things that can happen, syrinx, if anyone's heard of a syrinx or a syringomyelia, essentially it's sort of a fluid collection within the center of your spinal cord that can happen to some people, not many, but to some people after spinal cord injury. It can cause new pain, often new pain, kind of almost like a cape distribution over the arms if it comes up into your neck region. You know, these are things that if they're left untreated, it can gradually lead to worsening sensation, gradually lead to worsening motor function. So these things need to be worked up. And even something as simple as carpal tunnel syndrome or an ulnar neuropathy. If you have a thoracic level spinal cord injury and you have really strong hands, you don't want to lose that. You rely on that every day. So, you know, if you start to get new pain and symptoms in your hands, have it worked up, have it treated, because the last thing you need is to lose hand function because of some other kind of nerve damage. So if you're interested to know what kind of studies are happening now or actually considering joining a study, there's always clinicaltrials.gov. It can be overwhelming. These are all the studies internationally that are registered. The good thing about clinicaltrials.gov is these are generally very reputable. These, you know, it's not going to be someone that's charging you $20,000 to go to some island in Thailand to do stem cell treatment or something. You know, these are real vetted studies for the most part. You can filter by geographic region. And then the SCItrialsfinder.net is a great one. When you log onto that one, you can put in some specifics about your spinal cord injury level and about where you live, and it can tell you what kind of studies are happening in your area. So, all right. Anyway, thank you everyone for your attention. And I think I came in just under the hour timeline.
Good job.
But if anybody has any questions, I'm happy to try to answer them for you.
That's great. Thank you, Elissa. Go ahead and stop sharing your screen so that
Yes.
people can see your. So we have a number of questions. The first question is from someone who has their own psychology practice. They have a spinal cord injury. They want to know if what your knowledge is about the Spiegel type hypnosis.
Oh, I don't know about it specifically. My apologies. I'll have to read about it. I did read, you know, when looking at sort of the virtual reality side of pain management in general, they do talk about hypnosis. They've, you know, tried to sort of incorporate it into these larger systematic reviews, and there's some evidence for it, being effective for some people. But I will have to read about that one. I have to get back to you. I don't know specifically about Spiegel type hypnosis.
Okay, not a problem. Next question. In cervical injuries, does IT morphine, or I might be sort of misreading that.
Yep.
Right. Does it actually need to reach the sort of the injury to be effective, or doesn't the medication sort of drift down the spinal canal?
Yeah, so it's a good question. Yeah, it does. I mean, gravity is going to pull the medication down. They do try to implant the pump. You can implant the pump down low and then sort of feed the catheter up higher to try to get to the area where there's more pain, and to try to affect the nerves as they're exiting more in a distribution of where your pain is. But yes, some of the medication is going to come down. It's similar for intrathecal baclofen pumps. We know that in general, intrathecal baclofen pumps that are used for spasticity, they work much better for spasticity in the legs than they do for spasticity in the arms. And we do try to thread the catheter up higher to try to get it towards the arms, but it doesn't work nearly as well. So the same is true when it comes to pain, that depending on where your pain is, it may not be as effective if your pain is at a much higher level, like in your arms, for example.
Okay. We have someone who was injured 9 months ago with a cervical injury, and she is taking gabapentin, but her pain level from shoulders to her elbows is just immense. Again, she's taking gabapentin, and she's also doing some sort of rubs with dictofonics. I can't really pronounce it. And she's not getting sufficient relief. What do you think could be the next step for her?
Yeah. So one thing I didn't mention about the gabapentinoids in general is it's not entirely known the mechanism yet, but it's not a bad thing to have been on one of them early after injury. There's some evidence to suggest that people that are on gabapentinoids early after injury actually have improved outcomes from their spinal cord injury. So, you know, we do, you know, in some cases we will prescribe them whether or not you have any neuropathic pain because there's this association. So having been on it, it's probably not a bad thing. You know, again, I'm not going to be prescriptive and tell a specific person what to do. I don't know all the details about a spinal cord injury. You know, if I had someone and gabapentin by itself wasn't working, you know, obviously there's different doses of gabapentin. I often, if I start going up, I do really make a point of not just going up and up and up and up and then adding the next thing and going up and up and up and up. I often will take somebody up to a reasonable dose. So gabapentin, you can take up to 3,600 milligrams a day, so like 1,200 milligrams 3 times a day. If I start to hit around 900 3 times a day, and I'm not really seeing a lot of benefit, what I often will do before going up is I actually will try coming down, because when you come down, you can start to see, well, was it actually doing something and I didn't even realize it was doing anything? So sometimes by coming off of a medication, you can see, was it even helping? And if you start coming off and it's not, you don't notice any difference, well then great, get off of that medication, because it's just one more medication you don't need. So yeah, you know, for some people, Lyrica works better. And some people would argue better evidence for Lyrica, some people would argue not. But, you know, Lyrica could be an option. Otherwise, you know, yes, the antidepressants, the SNRIs, like a duloxetine could be helpful if there's other depression going on. And sometimes you do have to go into the other anti-epileptic choices. But if you have, you know, the opportunity to do any of the non-pharmacologic options, you know, obviously if you can avoid medications, it's great to try if you have some of the other things available.
Next question from someone is a T4. They're asking if you know of any providers for the VR walking.
I do not specifically know. Yeah, unfortunately, we are not doing any virtual reality studies at the Valley or at the VA right now, specific for spinal cord injury. So yeah, again, I would refer you to the, you know, SEI Trials Finder, or I mean, the good thing about VR is that anybody can get VR. I mean, you can experiment with VR. You're unlikely to hurt yourself. You know, if you have a VR system and you're watching it and kind of seeing what effect that has for you. But unfortunately, no. And at least in the Bay Area, I'm not aware of anyone doing it.
Okay. The same person is asking if you are accepting patients either at the VA or at Santa Clara Valley Medical Center.
So if you're a veteran, yes, you can come to the VA, but you do have to be a veteran. And at the Valley, unfortunately, my role there is as an extra help provider. So I fill in when doctors are gone. And so I don't have sort of my own panel of patients. I cover on the inpatient unit for acute rehabilitation when there's other doctors that are out. Yeah.
What would be your top recommendations to minimize risk for developing chronic pain in the acute, subacute phase of rehab?
Yeah, so, you know, I think that the type of pain medication used early is important. I think trying to minimize the use of the opioids as much as you can, and that may be why there's this association with early use of gabapentin or Lyrica and better motor outcomes. Perhaps people that are using gabapentin and Lyrica are not using as much opioids, and maybe that's what's making them have better outcomes long term, and also in terms of their pain. But, you know, it has been shown that people from any situation that get hypersensitized to pain early on will often have more pain for a longer period of time. So you do want to get a handle on your pain. You don't want to necessarily be stoic and be going through acute rehab in horrible pain the whole time. You do want to get a handle on it. And sometimes, again, it requires some experimentation. You may have to try a few different medications to try to get on top of it, and also work with your therapist. I mean, sometimes it's this combination. Pain is rarely one thing early after spinal cord injury. It's often nociceptive and neuropathic. And some of that other type of pain you're having to do with the brace, to do with your chair, you can have adjustments done with your therapist, with your seating, with other things that are all super important, or even just, you know, exercises that you could be doing. But again, it's tricky. It's such an individualized thing. My pain assessments take a really long time for each individual person to try to get at all the different components and try to tackle each element of the pain. And each one might be a different medication or a different therapy. And it's not usually simple, unfortunately.
Okay. Do you have more information regarding the use of opioids causing decreased motor return in the acute phase?
Yes, I can share it. In the bottom parts of my slides, I do have some of the references, and I'm happy to share where the references on those if people are interested. Yeah.
All right. Next person is taking both baclofen and gabapentin. What are the pros and cons of taking both of them simultaneously in high doses?
Yeah, so, you know, I think that it is important to note that spasticity can cause pain. And so, you know, in some cases, you may not need a pain medication if you can treat the underlying spasticity. So, you know, does baclofen work for everybody? No. You know, I think sometimes different antispasm medications or strategies there are important. it can be helpful, yes. I think similar to pain management, it's important with spasticity management not to just keep going up and up and up on a medication and then add the next one and keep going up and up and up, but maybe even try coming down a little bit to see if it's helping with spasms, because baclofen doesn't help everyone. But I don't think, there's some theories out there that use of baclofen and it can actually sort of affect some of the natural plasticity and healing of the spinal cord. It's only theoretical. So, if I have patients that have a lot of spasticity that's affecting their ability to do rehab, it's more important that they're functionally able to do their rehabilitation to me than to keep them off the medication. But by the same token, if you don't need baclofen, I'm not going to prescribe it. So I don't think that in combination, they're not necessarily synergistic, or they don't necessarily interact in a way that is harmful. Gabapentin actually has been shown to have some effects on spasticity. So for some people that have milder spasticity, just the addition of gabapentin can actually be helpful for their spasticity as well. So I wouldn't be concerned about that combination. I would say, if you're in acute rehabilitation or early on, probably 90% of patients are on that combination.
Next question, the person is asking about lithium. And aside from that, I know the researcher is using lithium as part of a clinical trials in order to get people walking. What kind of studies have been conducted in support of lithium?
Yeah, so this was one I actually only discovered this year when I was lecturing for the residents. There's a study out of China that looked at lithium for neuropathic pain. It did find that it was helpful for a specific type of pain. I believe it was more of an allodynia pain, which is like a hypersensitivity pain. Lithium is a medication that is classically used for bipolar disorder, for sort of mood regulation. It does require that it remains at a stable level within a sort of a narrow therapeutic window. And so, you do have to be tested with lab values and blood draws to make sure that your lithium level is at a safe level, because otherwise you can't have significant side effects from lithium or lithium overdose. I've never used it for pain. It's something, like I said, newly introduced to me this year. And I don't want to say anything bad about any specific researchers, but there is a different there's a different amount of scrutiny that sometimes goes into studies coming from one country versus another. And so there's also supposedly been some people that have repeated some of the work with pain and lithium in the United States, and oddly I could not find the reference anywhere. So I wish I knew a little bit more, but it's something that I myself am interested to see where that could go.
Next question is seizing up or inability to move, especially towards the end of the day, considered a spasm? Not sure.
Probably. I don't know. I don't know for sure. I mean, certainly sometimes somebody's pain can be severe enough. Pain can kind of cause spasticity. They can kind of affect one another. Classically, I think of people's spasticity as being worse first thing in the morning after someone's been lying, still not moving their muscles. That's classically when spasms are the worst. But I don't know, maybe.
Okay. What are the long-term effects of baclofen pump?
Of a baclofen pump?
Yeah.
So, long-term effects, there's generally not, if you have one for a long time, there's not a whole lot of concerns about people having them for life. The reality of the situation is most people who get them, you have them for forever. The biggest concerns for people with baclofen pumps is that while the dose is very, very small on a whole body scale, it is a high dose directly on your spinal cord, directly on the nerves. And so if you go through withdrawal, if you don't make it in every 3 to 6 months for your refills or whatever your interval is, to go through withdrawal is life-threatening. And so, that's really the biggest concern with baclofen pumps. Additionally, obviously it is hardware that is going into the spinal canal. And so, over time, there can be issues with the hardware. There can be issue with the leads or the catheters that are going there. They can break, they can have damage. And so, it is something that they do have complications. They do require changing of the batteries and all these things over time. So they're not, it's not a simple thing to have done, but if you have significant spasticity, they can be very life-changing for people because the medication is much more contained to your central nervous system and you don't have all of the other effects that you have when you take it orally.
Okay. Next question, what is the mechanism for feeling pain below the neurological level region in a complete spinal cord injury?
Yeah. So again, I could have put 1,000 slides just on these mechanisms and I tried to keep it pretty pretty simplified. But, you know, the basic idea is that, you know, in that area where the spinal cord is damaged, and that could be, you know, as high as your neck and you're feeling pain down in your legs, is that there's, you know, all those nervous, or all the axons and the white matter tracts that are coming up from the legs, they're still going through that area of the spinal cord damage, and they're still going up to the brain, or the brain is still has an area that is trying to perceive what's going on with your legs. I sort of analogize it to people that have phantom limb pain after they have, you know, a limb removed. You know, your brain expects your foot to be there, and your brain has a specific area that is dedicated to your foot. And it wants to feel that foot, and it's always supposed to be feeling that foot. And so when it's gone, that area of the brain wasn't removed. It's still there. And it still is trying to process signals and process whatever it's getting and saying that something's happening to that foot. And so, you know, similarly, if you have a spinal cord injury, this is all hand wavy. I mean, this is a little bit sort of how I think about it. But, you know, within the spinal cord where there's that damage, we know that those nerves that are going through there, they're hyperexcitable. They've got, you know, inflammation that's changing the way that the ion channels are, you know, releasing ions into the cells and causing, you know, nerve signals to fire. That's causing signals. It's causing signals that are getting sent to those areas of the brain, even though the signals themselves are not coming from that area below the spinal cord injury per se. I mean, you could have a complete transection of your spinal cord and you might still feel things below there. It's where your brain is perceiving it. It's not necessarily coming from that place itself.
Okay. Next question. Why would physical activity make my neuropathic pain worse? Should I keep doing it or lower it? I'm basically doing easy adaptive class or short walks.
Yeah, I mean, that's unfortunate that it's making it worse. You know, the evidence suggests that it should make it better, that it's anti-inflammatory to do exercise, that actually affects some of the ion channels within the spinal cord. Even a talk that I went to last week was talking about that. And so, you know, it should, most cases, help people's neuropathic pain. Again, it depends where your pain is. Certainly if you have more of a peripheral nervous system damage or something where there's compression on a nerve that's being affected by your particular exercise, that could be aggravating. And I mean, honestly, this is the problem with neuropathic pain is, as I was trying to allude to in the beginning, everybody's neuropathic pain is so different, and the exact mechanism behind each type of pain is different. So they have pains that, you know, pain that's considered to be more, that you can induce versus pain that's just always there. And so there are types of neuropathic pain that are more contingent on touch and movements. It's not just nociceptive pain that can happen when you move a joint. There are types of neuropathic pain that can be elicited by movements or activities. So it's unfortunate, I would say, if you can bear with it, you know, that activity, whatever activity you can do, it's going to help in so many other ways, hopefully with mood, but also just cardiovascular risk profile and everything else. That, you know, in general, whatever activity you can find, and maybe trying a different activity, you know, if you're ever allowed to get in pools and, you know, other things like that, maybe try something else. But it does obviously have other benefits.
Okay. What about ketamine infusion, if I'm not mispronouncing
it? Yeah,
ketamine.
Yeah, so I didn't talk about ketamine. It has evidence. It does. You know, it has risks. Ketamine is a drug of abuse, so it's only done in controlled settings. It can be very effective for people. It acts on sort of the NMDA receptors, which is just a difference, sort of similar to opioids, but it is very different. So it can be effective. I know that at our center at the VA, I've spoken and had a lot of conversations with our pain management providers. They don't offer it, so it does depend on where you go. In my internship training, you know, I had patients with severe bouts of pain, not spinal cord injured, but other individuals that would get ketamine infusion. So it is out there. It can be effective for people, but in terms of that becoming a medication that you can use really in your day-to-day life, I think we're a long way from that.
Okay. Impact of nerve block procedure on a complete versus incomplete.
Yeah, so probably going to work better on an incomplete injury. If for the most part, nerve blocking procedures are affecting the peripheral nervous system. So, you know, it is important to note that, you know, sort of the newer science or way that we talk about complete injuries is not as simple as we used to think about it. You know, if you have what we call, you know, your A injury, your motor sensory complete injury, probably up to 70 or 80% of people that have a motor or a sensory complete injury actually are discomplete, which means there's probably still some connectivity, you know, throughout your spinal cord. So it may not be as complete as we used to think that it was. But, you know, so maybe I would say if you have a true complete injury, like a cord transection, and you try to do some kind of motor block below the spinal cord injury level, there's no reason why that should be helpful, because those signals should just be completely cut off before they get to the signals that are actually making the brain. If you're doing it above your level of spinal cord injury, if you have an incomplete injury, then, you know, certainly that could be more effective. And if you have, you know, a discomplete injury, which you probably wouldn't know, you know, which category you fall in, you know, a lot of them are relatively low risk, so you could try. The problem with some of the nerve blocks is if you pick a nerve that has sensory fibers and you block that, sometimes it can cause more pain, more paresthesias or dysesthesias or discomfort. So, you know, it does depend on which nerve you pick, and sometimes increased pain can be a side effect.
Okay. What is your vision for the future of neuropathic pain management and SCI?
Yeah. So personally, you know, what I'd really like to see is that that we're really able to understand these different types of pain and be able to treat them specifically. I don't like the fact that when somebody comes in, you know, I have a long list of medications I can try, but it might take 6 months to get to the one that actually starts to make a difference. It would be great if we could really start to understand these specific pain types. Like I'm talking about the, you know, your tingling pain versus your burning versus your allodynia and whatnot, you know, where it is, what it really feels like, to then be able to say, this medication is the most likely one to work for you. Let's start there, instead of everybody start with gabapentin, then everybody move on to Lyrica, then everybody move on to nortriptyline. I mean, it's, you know, you can be uncomfortable for several years before we get to the thing that's going to work for you. So, so that for one, and then obviously it would be great if we had more options that actually worked. We still don't understand the pathophysiology and the mechanism well enough. There are things in the pipeline, but you know, this is a long pipeline. Unfortunately, things can take a long time. But certainly to have a few more options would also be great.
Okay. And last, we had a couple of questions asking about clinical trials that are recruiting subjects. But I think you deferred everyone to the clinicaltrials.gov website, right?
Definitely, yeah. I would check clinicaltrials.gov or the SCI Trials Finder. That one's easier to navigate because it more quickly determines whether you are going to be eligible for specific trials if you enter your spinal cord injury level, completeness, and also the geographic region is helpful. If you look at clinicaltrials.gov, you might find a really interesting study happening in Germany. So, you know, you could go to Germany, but you may not want to, or may not be able to. So it can tell you what's out there, but the Trials Finder may be a little bit better in terms of finding things that are local.
Okay, very good. Thank you so much, Elissa. This was wonderful, very, very informative, lots of information. It's frustrating as heck for most people because there is no sort of viable solution, at least not in near term, and we're just sort of, doctors are doing the best that they can.
Yeah.
But thank you so much. Once again, everyone, this presentation was made possible by the grant from the REEF Foundation. Thank you so much for your time, Elissa. And once again, it'll be made available via recording and you'll all receive it in your email early part of next week. Have a great rest of the night and a good weekend and stay safe. Thank you again, Elissa.
Very welcome. Thank you so much, everyone.
Take care. Bye-bye.